All right, Pinahil, go for it.
Okay. So, this is a story of a 50-year-old male who presented to the clinic with weakness and dizziness for 4 days. The patient presented with the persistent symptoms of generalized weakness and dizziness that began 4 days ago. 1 week prior to these symptoms, the patient experienced an episode of moderate chest pain, described as a pressure-like sensation that radiated to his left arm. The chest pain was severe in intensity and lasted for approximately 20 to 30 minutes before spontaneously resolving. The patient did not seek immediate medical attention as the pain subsided on its own. The patient did not, and the patient, like this, since the episodes of the chest pain, he has not experienced any further chest discomfort but continued to feel weak and dizzy. The persistence of dizziness and weakness prompted him to visit the clinic.
All right, that's a rich start. Parisa, what do you think of the information?
Thank you, Minha, for putting the case together for us. I think if I want to start with weakness and dizziness, generally these two chief complaints are non-specific and have a broad differential diagnosis. It could be neurologic, it could be cardiopulmonary, and it could be infection as well. But I think when we are having multiple chief complaints, it's better to start with the one it's most morbid and the one we are more familiar with it. I think for me, it's usually weakness. I know that for approaching the weakness, it's better to make sure that it does not accompany with any muscle weakness, because if it is accompanied with muscle weakness, it is guiding us through, it's localizing everything to central nervous system problem. But when it is just weakness alone, probably, which is meaning that patient is describing the things who are explaining in another term, which meaning weakness, which is it could be the mimickers of many things, including pain, cardiopulmonary, lots of their cardiopulmonary reserving compared to their baseline, or it could be infection as well. But this patient specifically have another kind of presentation. He's specifically have chest pain, which is having episode of the chest pain 4 days ago, which is having pressure-like sensation, which is radiating to his arm, which is, we all know, it is so specific for the acute coronary symptom problem, although it has passed for 4 days. But I think that it is changing my differential diagnosis profoundly. I think the first thing I'm thinking of now, it's coming to the top, it's cardiopulmonary things first. And for approaching the dizziness, I think usually people, again, describing dizziness differently. It might be some prodromal pre-syncopal sensation that is interpreted as dizziness. I think at this point, I need to ask about any past medical history. Does this person have hypertension? Do they have diabetes? Do they have previous episode of cardiac specifically problem? And then we could start from there.
That was so great, Parisa. I loved it. And yeah, like weakness and dizziness are like such challenging chief complaints because as you mentioned, they're just like the differential for them is so wide. But I love how you were differentiating between like, okay, is this weakness, is it asthenia or is it actually true muscle weakness? And with dizziness as well, like thinking like, oh, is this like orthostasis? Is it related to the chest pain or not? I totally agree that it's like really hard to make much progress with the information we have now. So I think if we want to summarize this, sounds like this is a 54-year-old gentleman who had this episode of like acute onset chest pain that resolved a week ago, and then a few days later has had developed like what it sounds like a generalized dizziness and weakness. So I think for me, one of the things that I'm grappling with are these two episodes related to each other? Was that the chest pain, was that a significant event? And I love that you kind of focus on the cardiopulmonary, because I think just like asking the quiet part loud is like the question I'm asking myself, like, did this patient have an acute coronary syndrome at that time, right? This patient have a heart attack that it got resolved, didn't present to care, and now is developing complications of that, and that they're perceiving as the weakness and dizziness. And you know me, I love my no misdiagnosis. So in this context, I think I agree with you that I think for me, the cardiopulmonary system is like one thing to investigate, because that history of like, chest pain that is severe in intensity and then kind of radiating to the left arm really is a good story. It doesn't mean that it is, but at least like it's a good story for your no misdiagnosis, which is like, the acute coronary syndrome, thinking about dissection, all of those things as well. But I think the focus, as you mentioned, is going to be on cardiopulmonary system. And then I think like with the weakness and dizziness, usually with the weakness, I like when I'm seeing a patient like this, I'll just like do a quick neuro exam to prove and get a sense that is it truly just like a generalized weakness asthenia, or is there a focality to it? And if there's focality to it, then I think more about like that weakness tree of like and schema of what is causing it. And with dizziness, again, the same, getting a sense of like, is it positional? How is this patient experiencing this? So I think like a little bit more detail would help us like make a bit more progress on that as well. Beautiful discussion, Parisa. Manahil, I can't wait to hear some more.
Awesome discussion. So his past medical history was not significant. He was non-smoker, did not use illicit drugs or consume alcohol. He has no recent travel history, no known allergies, no significant family history. So, upon entering the room, the patient was lying comfortably on the bed, talking to his wife, and he was well oriented to time, place, and person. So, upon initial assessment, his vital signs were like a bit hypotensive. He was with a blood pressure of 77/57. Heart rate was 90 beats per minute. He was afebrile. His respiratory rate was 20 breaths per minute, and he has oxygen saturation of 96% on room air. Going towards examination, there was no lymphadenopathy, no JVP raised, no rashes or lesion, bilateral normal vesicular breath, heart sounds were S1, S2, no murmurs, and his abdomen was non-tender, bowel sounds were positive. His GCS was 15 out of 15, and there was no cranial sensory or motor defect.
Okay, I think at this point, I am somehow relieved that we are not facing a neuro patient, and I think I can I can keep my focus to cardiac problem. And I think when I'm facing a blood pressure of 77/55, it is that one of the time I need to think about resuscitation and think about RX/TX. I need to think about what should be the other steps for me before taking the diagnostic step. This patient does not have any lymphadenopathy, which is taking me away, and he's not febrile. I'm not thinking about infectious causes. I think I'm mainly focused on cardiac causes. I would like to get EKG. I would like to resuscitate them. I would start IV fluid therapy. I will probably get a cardiac consult. And I think I will I will put them on telemetry, and I will put them on oxygen support. I will try to stabilize patient generally, and I think I should start like that.
No, yeah, absolutely. I think you picked up the most important in a part of data here, and that is that blood pressure. And I love how you're thinking about like, okay, what do I need to do first in terms of like management rather than like just the diagnosis. And I think that's a very excellent way of framing this patient. And I agree with you with the focus that I think I'm worried about the heart. When I look at that blood pressure, what The narrow pulse pressure really has me worried about a cardiac etiology. So thinking about cardiogenic shock would be one. Again, like we can't call it shock yet because we don't know about the end organ damage, or but that is like usually like the hypotension shock is a framework that I usually run. And you think about like your distributive, your obstructive, and then sorry, cardio genic as like three of the possibilities. And I agree with you that I'm a little bit less worried for an infectious etiology. However, we're gonna get some more information. We're gonna get some more data. Um, the two things that I would consider in this case a little higher. Again, we are making the assumption that like, oh, that chest pain. Was that a cardiac event? And what could happen as a complication of the cardiac event is like acute heart failure, arrhythmias, valve a rupture. Cerebral rupture would be 1 week. Maybe not quite accurate, but again, like thinking about like tamponade, thinking about valvular pathology, thinking about also cardiogenic shock is I agree with you that I would like worry about a sequela of that. The sorry. The other things to think about, like, okay, is there anything else in this exams that is like reassuring or worrisome? The fact that he's like sitting well on room air, that's good news. And the fact that he's like laying comfortably in with a pressure to 77 to 57, maybe it'll give you like a little bit more room. He didn't have any elevated JVP, which, with that narrow pulse pressure. Um, I was like, "Oh, we're not really dealing. At least we know there's no evidence of like volume overload. That doesn't mean the heart is not on the hook, but we don't have any overt evidence of like heart failure." I think the fluid one is always a good question, whether to give fluid or not. And I think like the clinical picture will really dictate that. Oftentimes, if I'm really worried about distributive or hypovolemic, then I'm like, yes, resuscitate. In someone that I have a bit of concern, if you want to give fluid, I would be a bit more judicious. Maybe this is someone that I would start with smaller boluses and see how they do, like a 250 cc's for 500 cc's. But I would probably, if he was clinically stable, I want to get some data first to better distinguish between those two. Because again, if you're worried about cardiogenic, giving them fluid might not be the best, but nobody can ever fault you for giving small boluses. And I loved the idea of like getting an ECG, yes, getting cards involved. So like getting your ECG, your troponin, a lactate would be really helpful, and also like your a CMP, BMP to get another sense of like, okay, how extensive this issue is. And then this is someone that we don't have much past medical history on, right? Like we don't know if he has many comorbidities that hasn't been identified yet, or is this is like a seminal event for this patient. So I agree with you in a sense of like my focus again still remains in the cardiac world. I think if you're good, like POCUS would be really helpful here, especially if you want to take a look to make sure there's no effusions there, like get a good like a broad sense of like the systolic function of the heart. If possible, I think that's another good thing to do in this case. Any other questions or any other reflections, Parisa, about this?
Yes, I really like the part you were dividing the complications of the cardiac and non-cardiac. It could be arrhythmia for post-cardiac event, any heart failure, any a structural problem, including valvular, ventricular problem, or on the other hand, it could be also a thromboembolic problem or even post-angina, post-infarction angina problem. I'm looking forward to hear more.
Yeah. Yeah, go ahead, Minahil. Thank you.
Okay. So I want to show the EKG of the patient, and I'm not a co-host.
Sure. Let me make you a co-host. Here you go.
Is it visible?
Yes, it is. All right, maybe we'll just everybody can take like 15 seconds and take a look? All right, Perry. So ECGs are scary. Whenever somebody put an ECG in front of me, I was like I still become tachycardic. I'm like, oh, okay, and then,
Yes,
and then
they are.
like after like tachycardia induced ECG showing, let's think about it together. What jumps out to
Yes.
you?
I think the reason it's sinus, but I'm seeing some T version that it could be a sign of the myocardial infarction or any cardiac events. I cannot specifically justify about the ST elevation from the here, but I think there are some alteration at that point as well.
Yeah, I totally agree with you. I think like it looks irregular to me, and yeah, I feel like oftentimes I'm like quite basic in the way I look at an ECG. I'm like, is it concerning? Is it not concerning? Am I worried? Not worried? I'm worried. And you're absolutely right with like the T wave inversions. And the one that caught my eyes was, the V2, V3. There's like this kind of like biphasic nature of it. That reminds me of like the balance pattern against. Whenever I think is balance is not balance, but the key as like a hospitalist for me is like okay, like, is this concerning enough for me to call cardiology? And like with kind of like the balance pattern, again, it kind of goes with the story, like this ECG goes with the story that we were hearing from this patient, right? Like a week ago, this patient had chest pain. We worried that he had an event. And oftentimes, like what valence is like scary is because like we worry about like kind of like a high degree LAD left main disease and with like kind of the deep wave inversions that you see and the biphasic pattern of the V2, V3, that is like what made me like worry about kind of like the valence pattern. And yeah, absolutely, like this is an ECG that your Gestalt was absolutely right. You want to get those troponins. The chances are because the event has passed, it might not be elevated, but this is a story that I think worth a cardiology consult, as you mentioned. Mina Hill, did we miss anything about the ECG that you want to point out?
No.
Okay, great. All right, let's do you want to tell us some more?
Yeah. Okay, so going to the lab findings, his hemoglobin was 14.6, hematocrit was 41.8, WBCs were 6.86, platelets 274. In renal function test, his creatinine was 0.9, blood urea nitrogen was 25. His electrolytes and liver function tests were within normal limit. Going towards cardiac enzymes, his troponin I is 0.100, CK was 84, LDH was slightly elevated at 254, AST was 25. His echocardiographic study was normal, but his ejection fraction was 60%. In his lipid profile, his triglyceride was at borderline of 160. Cholesterol was 124, HDL was 34, and LDL was 74.
I think if you want to address the lab data, the thing that's coming to my mind, the good thing is that AST, ALT, and the creatinine is good. It's showing that we do not have any end organ damage and the patient is not in shock. And then the troponin is high. I think probably we need to push them on the consult again. Yes, I think, yeah, I think we need to see the patient as an acute coronary syndrome problem at this point, because I think that when we are having the balance syndrome, which means that indicating that the patient is in high risk of, I think, anterior myocardial infarction, and they are in the risk of critical stenosis, and we probably need to send them to the cath lab or whatever intervention they would like to take.
Yeah, I totally agree with your analysis, Parisa, is that, you know, that honestly, like the level of troponin, I was a little less concerned. Like if it's high, if it's low, I don't think it would have changed my calculation much because, again, the event was a while ago, and oftentimes, Velen does happen afterwards. Um, yeah, I agree with you. I think if we think about it as like we're worried someone has an obstructive pattern, and again, like common things being common, the most likely thing we're worried about is like a stenosis. Um, so the question is like, what would we do about it? And it's oftentimes like, a cardiologist decisions, but from my perspective, I can't like this patient, we really need to go look at the coronaries and see what is going on. And, any other imaging modality, I don't think would quite be the gold standard of a cardiac cath. The good news is, with the left heart cath, you can, his creatinine is okay. And also like you can get some better numbers. Like he's ejection fraction. Room 151, bed 2. Sorry, just wanted to make sure it wasn't a patient I was covering. Um, and you can get some more data. I think the ejection fraction is reassuring. However, that blood pressure still has me worried. So I think like getting better numbers at cath would be really helpful. And especially if you're still worried about, I think a lactate would be really helpful here. And also trending that blood pressure, I'll be curious to see like what direction that blood pressure is going. And oftentimes like in left heart cath, in terms of like management wise, if it's a big stenosis and need to open up, you can put like Impella, you can put devices that can support function if you're concerned about that. The other thing that I would be curious to get in this patient would be like a BNP to see what like the heart function is doing. I would have like expected a little bit of a lower ejection fraction, to be honest, but I'm glad it's maintaining. But I am worried this is patient is at like a critical state, so like a very close monitoring would be helpful. And I think I love the fact that you guys got lipid panels. I oftentimes thinking about like, okay, what are the risk factors and classifying that. With his LDL oftentimes 74. That's not terribly high. I would add like a hemoglobin A1C as well to the workup as well. And oftentimes we're now getting like APO on these patients too. So I totally agree with you. I think getting calling cards and then like trending the ECGs, making sure the patient remains chest pain free, trending that blood pressure, and then see what, and then we can see what happens next. All right, Minahil, back to you.
Okay. So, given the patient's symptoms and abnormal EKG findings, there was a high suspicion for coronary artery disease. The patient underwent coronary angiography. So, before giving the results, I want to show coronary angiography image. I'll share my screen.
This is the time that I usually call one of my cardiology friends, aka Dr. Kaylin One often, and send a picture. But let's I think let's look at this together, Parisa. What do you see?
I think there are some dentation and stenosis probably in the anterior side. I think probably I'm not the best person to interpret this.
Yeah, to be honest with you, like in reality, I would just pull a model, Google, just to make sure. I haven't looked at this in a long time, but I think I do. Probably like looking at the left main and then coming down LAD. I do think there's a kind of a more proximal LAD stenosis. And also like I think the circumflex that kind of looks rotates. I see some stenosis, like I see actually like multiple stenosis throughout the lesions and where like the tapering happens. Um so then the question becomes like which of these are like culprit regions, and there are a lot of fancy things cardiologists can do to try to figure out which lesions are the ones that they think is the problematic. But yeah, I think I kind of what I would say like I worry about like a diffuse like coronary artery disease, and then the question become I'm curious to see the actual read. I might be completely wrong. Oftentimes the question we ask ourselves if we're worried about like a multi-vessel disease is that would this patient uh, so, would this patient benefit from stenosis or would be better served by cabbage? And I think that's like oftentimes that's a decision that is way above my pay grade, but that is usually what the cardiologists and CT surgeons would decide together. And so whenever I think about like multi-vessel disease, I often think about whether a cabbage would be more appropriate for this patient. And the other thing we didn't really think of, talk about as much, about the management before the calf, given the event was what we thought was like about a week ago. But oftentimes, when you're worried about coronary artery disease, you often think about like heparinizing this patient, giving aspirin and statin. Usually, we wanted to dual antiplatelet load these patients. That tends to be here like a little bit more institution specific, especially if people can go to cabbage early. Sometimes surgeons don't like to operate on dual antiplatelets, so oftentimes people get aspirin, heparin, statin, and then oftentimes we leave like the second antiplatelet to the cardiologists. Uh, Mina Hill, can you teach us about this? What they saw and how off we were?
Okay. So like there was severe stenosis in the left anterior descending artery, and the patient subsequently underwent successful percutaneous coronary intervention with stent placement. And like Sharmin and you were all right. The patient was like diagnosed with type B variant syndrome.
Mhm. Amazing. So they only see like that was like the big LAD. Did they see any other narrowing, or was I just imagining it was just more tortuous vessels?
There were some, but like that was not meet the criteria for the PCI.
Got it, got it, got it. Wonderful. So it wasn't like it was like probably less than 50% narrowing it.
Yeah.
Okay. Wow, what an amazing case. And thank you so much for bringing the ECGs and also the CAT findings. It's a good reminder for me to go take another look at the cardiac anatomies. Parisa, any thoughts, any reflections?
Thank you so much, Minahil, for bringing this case. I was definitely stretching. It was so amazing and so educational. Thank you so much.
And how did the patient's blood pressures do? Minahil, were you guys at all worried about like cardiogenic shock, or did that got better?
Yeah, like after his PCI, it got better.
Okay, cool, 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 cool. Wow, an incredible case. Thank you so much. I love, 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 love bread and butter medicine. Parisa, you did such an amazing job. You were right on the money from the beginning, thinking about cardiac etiologies as well. And again, like I think like another good reason to always like the weakness and dizziness often can be very non-specific, and as we suspected, it was like most likely an ascending of his underlying cardiac issues. And sounds like did that resolve as well, Minahil?
Mm. Yeah. Yeah.
Oh, sorry. I was wondering if like the weakness and the dizziness also resolved after.
Yeah.
Yeah.
Sorry, there was a voice break, so I was not able to capture the voice. Yeah. And all her symptoms were resolved. Like he kept for observation under like for 1 day or 2 day, we kept him under observation and his all symptoms were resolved.
Uh, oh, wonderful. Yeah, and I think like now the dizziness we can probably it was like secondary to is like blood pressure and underlying coronary disease. And then I think the question that we have to ask, and not necessarily always like happens in the hospital, but why this patient has developed coronary artery disease? Is there any other reversible factors that we can identify? And I think like diabetes is a good one to make sure to rule out in this patient and kind of think about lifestyle modifications as we go forward. Anything else, Minahil, from this case that you learned that you want to share with us?
Yeah, like I learned like that how small but important signs like past chest pain and subtle EKG changes helps to diagnose severe heart conditions, and this leads to the life-saving diagnosis.
Beautiful. Amazing case. Thank you so much. Just gonna pass the mic to Mariana for the teaching points.
Thank you so much, Minahil, for this educational case. Thank you, Sharmin and Parisa, for the fantastic discussion. So today we had a patient with weakness and fatigue, which are non-specific symptoms with a broad differential diagnosis. So for them, if the patient has another symptom, sometimes it's more helpful to focus in a more specific symptom than weakness and fatigue because they are too broad. So thinking about weakness, we have to try to find any signs of fecality because if the patient has any, we should focus on neurological investigation for this patient. And then patient related a chest pain 4 days ago. So we have to think about STEMI, but we also have to consider MSK pain. And having these symptoms of weakness and fatigue and a past episode of chest pain, it's also important to try to think if these episodes are related to each other or if they are like separated events. And because of chest pain, we have to consider if the patient had a previous episode of ACS that got resolved and now is presenting with complications. So cardiopulmonary system must be investigated in this case. And then we found out the patient had low blood pressure. And so it's important to prioritize resuscitation, and at this point, management is more important than diagnosis. But because we may be dealing with a heart condition, it's very, very important to be cautious with giving fluids to this patient. So we also discussed briefly about hypotension shock that could be due to an obstruction or cardiogenic or distributive. We also discussed that it could be an arrhythmia due to post-STEMI complication. We could be dealing with valve ruptures, tamponade, cardiogenic shock. But at that moment, we had no evidence of heart failure because we had no GVD and no crackles. Further, we found that we had a high troponin with ECG showing signs of ischemia. So at this time, we prioritize ACS or maybe CAD, and patient needs close monitoring. And further assessing the ECG, we noticed V2 and V3 showing deeply inverted T waves, which is a sign of proximal LAD stenosis and is a characteristic of Welling syndrome, which ended up being the final diagnosis for this case. And just some more pearls here. When we have a multivessel disease, sometimes CABD will be more important than placing stents. And for this patient, we also have to investigate reversible causes for ischemia, such as diabetes and hypertension. Thank you very much.
That was so awesome. I'm always so impressed with you all doing teaching points. That was fantastic, Mariana. Thank you for doing the teaching points. Shout out to Sawson for doing the scribe. Parisa, amazing job. Amina Hill, what a pleasure. Thank you so much for presenting your third or fourth case? Third case?
Third case.
Third case. I can't wait for the fourth one.
It will be with you next Wednesday.
Yes, sounds perfect. I love this. Thank you all so much for joining us. It's an absolute pleasure. We'll see you tomorrow, hopefully. Have a good day. Bye, all.